Sources of data in health promotion. AI thrives on data, and so does health promotion. Without quality data, we can't understand population needs, track outcomes, or design effective interventions. Data helps us move from assumptions to action. The bottom line is no data equals no health equity. Let's look at the types of data. Census data, government health data, social determinants of health data, clinical data, administrative data, and patient-generated data like from wearable devices such as smartwatches. Census data. Census data is the foundation source of information about a population. The U.S. Census Bureau collects data on the population every 10 years. Data are collected on a range of demographic data: age, race and ethnicity, sex, marital status, income, housing, employment, family size, language spoken at home, etc. Government health agencies. The U.S. Department of Health and Human Services, HHS, is the primary federal agency responsible for protecting data. It includes many independent agencies that collect, manage, and publish national health data. HHS agencies cover everything from clinical research to epidemiology, health services, behavioral data, and health equity. Let's look at the HHS agencies. The National Institutes of Health, Centers for Disease Control and Prevention, Health Resources and Services Administration, Substance Abuse and Mental Health Services Administration, Agency for Healthcare Research and Quality, Centers for Medicare and Medicaid Services, and the Food and Drug Administration. While most federal health data comes from HHS, other agencies outside of HHS collect data that's relevant to public health and health promotion. These sources may focus on environmental, occupational, agricultural, or educational health factors. Health promotion professionals need to be aware of cross-agency data tools. Some of those other government agencies include Environmental Protection Agency, the U.S. Department of Agriculture, U.S. Department of Education, U.S. Department of Labor, and the Census Bureau. Healthy People 2030. The Healthy People 2030 and the upcoming Healthy People 2040 initiatives are produced by the Office of Disease Prevention and Health Promotion within the Department of Health and Human Services. Let's look at social determinants of health data. Social determinants of health data captures non-medical factors like housing, food access, transportation, and education. Examples include the County Health Rankings, American Community Survey, and the CDC Places. These data are used to design interventions that address upstream issues like safe housing or transit access, not just clinical needs. Clinical data is what's captured in healthcare settings, things like diagnoses, lab results, and medications. Sources include electronic health records, health information exchanges, and disease registries. Clinical data is often rich and longitudinal, but may lack context on daily life. Privacy regulations like HIPAA must be applied. Administrative data is generated for billing and operations, not clinical care. Examples include health insurance data, Medicaid or Medicare claims, and hospital discharge data. It's useful for studying cost, utilization, and access trends. Patient-generated data comes from outside the clinic, like wearable fitness trackers, mobile apps, or health surveys. It captures behaviors, lifestyle, and self-reported outcomes. These insights are key for tailoring programs, especially in mobile health. But beware of digital equity issues, since we do not know who has access to the tech. Structured versus unstructured data. Data comes in many formats, but not all data is organized the same way. Understanding the difference between structured and unstructured data is essential for using the right tools to analyze it. Structured data is organized and formatted in a way that makes it easy to search, sort, and analyze using databases or spreadsheets. Examples include patient surveys, drop-down menu responses, lab test results, diagnosis codes, and demographics like age, gender, and zip code. Unstructured data is more free-form and doesn't follow a standard format. It includes text, images, audio, or video. While harder to analyze, it often captures context and meaning that structured data misses. Examples include provider notes in an electronic health record, open-ended survey responses, focus groups responses, social media posts about health experiences, and patient journals or interviews. With the rise of AI and natural language processing, public health professionals can now extract insights from unstructured data in ways that were previously impossible. Let's look at an applied case example, diabetes prevention in rural Florida. What data would you use? Census data to identify who's at risk, BRFSS data to understand behaviors, EHRs or registries to track chronic diseases, and social determinants of health data to address barriers like transportation or food access. This is where multiple data sources come together to build a complete picture. In summary, health promotion relies on many types of data. No single source is enough. Each type has strengths and limitations, and integrating multiple data sources leads to stronger, more equitable programs. And as future health professionals, your job is to ask, who is represented in the data and who is missing?